We're going to kick off, if we can. This is not being live streamed, this session, you'll be pleased to know. Please do feel free to ask questions. One of the objectives is to be as interactive as we can on the one hand, but also we'll have some questions at the end. We are going to re-ask that last question with a no. You'll be pleased to know. I'm told the live stream went out really well. I think this is a more complicated session. I think it is. And I also think it's an important session because I think it will define aspects of the future of the disease. I made this slide on the aeroplane as well.
You're very productive on the airplanes.
Yeah, actually I'm good at planes. I should spend more time on planes. This slide gives a color-coded insight into ADC development in urothelial cancer. Enfortumab vedotin we know about, and I'm not going to go into too much detail around that. Obviously the targets there, the payload, the biomarker selection, ongoing randomized trials. So those are the only randomized phase 3s I put in, practice-changing randomized phase 3s. Grade 3 or 4 treatment-related adverse events. There's some grayness around T-DXd, depending on you put the entire cohort in or just the 16 patients. Those little bars are response rates in refractory disease. T-DXd only represents the HER3 positive patients. Disitamab vedotin, HER1 to 3 positive patients. So they're a bit unfair because they're biomarker selected, or some people might argue the way around saying they're really fair because we should be doing biomarker selected work, which we'll talk more about in a minute. And then bottom, the pie chart is associated with a combination with immune checkpoint inhibition in unselected patients. And the bicycle drug, well, I'll go through them. So we know Enfortumab vedotin, which targets Nectin-4. Sacituzumab govitecan is TROP2 with topoisomerase 1. Disitamab vedotin has actually got the same payload as Enfortumab vedotin, and that has a complication associated with it because there may be cross-resistance, and we're going to talk about that. T-DXd is HER2 and topoisomerase 1. And these two drugs on the far right-hand side, I think those are the two least mature drugs. The first one is BT8009. It's called the bicycle drug because it has a different technology from the other drugs. And then BLB01D1, that agent is a HER3 EGFR Topo1 ADC presented at ESMO just recently, only data out of China available to us. So the first section of this is going to be around Enfortumab vedotin. We're not going to talk for too long about that. We could do the whole session, but it's about drug development, not about where we are today. But I thought this poster from ESMO was one of the really important posters because here you can see a 40% 5-year OS in cisplatin-ineligible patients with urothelial cancer. We can also see on the left-hand side in the dark grey patients on therapy, but in the light grey there are lots of patients who are off therapy having responded to EV Pembro. So it tells us two things. Firstly, it's not EV Pembro forever. There is a degree of stopping therapy. Now there's an art associated with that, and a lot of that is currently driven by toxicity, and that's important to recognize. And then second, on the right-hand side, the EV302 results, the randomized phase 3 with a 50% reduction in the risk of progression, 50% reduction in the risk of death, 30% CR, 70% response rate, it's always tracked above the EV103. One of the unusual things was the randomized phase 3 outperformed the phase 1. And the reason why that was the case is this is cisplatin-ineligible patients, and so these patients are slightly less well-nicked than some of the patients that we put in EV Pembro. But if EV Pembro had a 40% 5-year OS, may or may not, but if it tracks this, how would that change our thinking of urothelial cancer? And Shilpa, let's start with you.
I think that will certainly point towards that we are curing a lot of patients. You know, historically 5% 5-year overall survival rates to over 40% and that is just with frontline therapy, is really remarkable.
Kala, what do you think about patients stopping therapy? And when you treat patients with EVP, what do you do? What do you say to your patients about how many cycles they're going to have? And I come in, I'm sitting there thinking, oh my God, am I going on forever? What do you say to your patients? I'm looking forward to responding. It's very important I respond. But how long do I need to have? How long am I going to be on this drug for?
Yeah, it's a great question, and I think that some of our real-world data might help to understand this a little bit better. I tell all my patients that there's a very good chance that they will be dose-reduced during the course of treatment. We saw data from Dan Petrolak showing that many patients get dose-reduced, and despite dose reductions, we are still seeing responses. And the reason I do that is because I want patients to report toxicity, because they may not want to, precisely because they want to stay on drug and they want to keep their response going. It's really a cycle-by-cycle assessment. The main toxicities I'm looking for are neuropathy, skin rash, and diabetes. Those are the ones that I perhaps think about the most, but it's cycle to cycle, and then often I'm using low-dose steroids to try to maintain treatment. But I think there'll be a subset of patients that will get EV Pembro for maybe 4 to 6 cycles, but due to toxicity or other reasons may drop the EV and maybe go to Pembro alone, and maybe ctDNA one day will help us.
Andrea, you and I chatted about management of toxicity and baseline assessment of patients receiving EV Pembro. Which patients do you feel one needs to be cautioned before we start therapy, and how do you discuss toxicity management with the patients when you start?
I think we're still learning from the toxicity. This is a very unique toxicity profile, and as data matures and as more people use it, so I think that's why I really like databases, real-world databases, because they really help us. But I think we're learning. Patients that we have some concern about are hyperglycemia patients that have hyperglycemia. That doesn't mean that diabetic patients shouldn't enroll. And patients that have baseline neuropathy, that doesn't mean that patients, if you have baseline neuropathy, you shouldn't enroll. There was a really nice data set that was presented at ESMO as a poster on patients that had diabetes and patients that had baseline neuropathy and still received EV and still did well. So it's a matter of us learning how to dose reduce, how to manage the toxicities, stop it if needed, and then restart it. I think it's all an area that's evolving as we get more familiar with using this agent.
And in terms of managing the toxicity, Andrea, early skin rash, is that just a case of stopping the drug and peripheral neuropathy when it occurs? Are there any magic tips around that, or is it just about being very vigilant and stopping the drug very quickly when they occur and restarting at a lower dose?
Well, it's not all size fits all, so It depends on the level of the rash. Can you manage it with topicals? Do you need to include orals? Do you stop it and hold and kind of see, because pembrolizumab can also cause a rash, like what's actually causing it. So, and then, what's the level of the neuropathy? There's also motor neuropathy, not only sensory, associated with it. If the patient can't walk well, which has happened in some of my patients, they start getting kind of a shuffling gait. That's time to stop it and reassess. And most patients can be salvaged in terms of their toxicity with stopping and holding the drug, but it depends how much they've gotten. It is cumulative. So I think all of that, there's no magic bullet, but there are some very clear guidelines depending on the grade that you would give the toxicity as to how to manage those patients that are part of the investigator brochure and the guidelines that are out there right now.
Petros, how many of your patients get above 10 cycles of drug?
I would say that probably, first comment, the majority of my patients have dose reduction. I would say who makes it to 10 cycles, it probably depends, maybe a little bit less than half, about half patients or so. And almost all those patients have dose reduction. I agree with everybody that speak before me. I look for a reason to dose reduce, especially after the first couple of cycles. When I get a good control of disease based on Dan Petrolak's data, I look for reasons to dose reduce, and I discuss with the patient up front that it's okay to have dose reductions. Do not underreport. Talk to us, let us know skin changes, neuropathy, fatigue, appetite, whatever side effect there is, because I think it will be relevant. It's a marathon, not a sprint, and those adjustments are critical to maintain this marathon. Reduction, delays, and sometimes occasional discontinuation based on toxicity-driven approach.
Nectin-4 is expressed in almost all urothelial cancer patients. The H-score out of 300, so if you've got 100% of your cells staining, you get 100, and if they're staining 1+, you get a score of 100, 2+3, 200, 3+3. So to score 300 is actually quite difficult. It means all the cells staining a lot. If only half the staining a bit, you get about 150. And here the median is 150. I think this demonstrates that Nectin-4 in urothelial cancer seems to be quite closely correlated with each other. And the outcome data across the board in the EV302 study, I think it's fair to say that EV-Pembro outperforms platinum-based chemotherapy. Are there any patients, Shilpa, who you'd be choosing platinum-based chemotherapy over putting the are there any platinum-based chemotherapy patients left?
Not really.
And what do you think, Petros?
I think Nectin-4 protein expression is not a good biomarker to select our patients. You showed great data, Tom, a couple of weeks ago at ESMO that there was no clear correlation with the degree of benefit, so the benefit applies regardless of the protein expression. But I would love to see more data. I applaud the effort of biomarker approach. The first time we saw biomarker data with Enfortumab vedotin, so we like to see more data. I want to see maybe Nectin-4 amplification. There is some discussion about Nectin-4.
We're going to come to Nectin-4 amplification here. This shows the relationship between PD-L1, Nectin-4, and outcome. And again, there doesn't seem to be very much there. So from an IHC perspective, there is no role to play. But there is some data kicking around on this Nectin-4 amplification. Andrea, who would anyone like to take on this issue? Because this work's coming out of the German group.
I think this is important. We want to make sure that the patient has the target and who are the patients that are going to respond the best. The only issue with biomarkers is, does that mean that if they have low amplification, we don't give it to them? And do we have something better? That means that they're going to do better with chemotherapy? We don't know that answer right now. So I'd say for now, this is evolving, and I think it's important to kind of really get into how to best measure the target in the patients that you're treating. But then how to use it, that's a second step.
If I can think of a renal cancer parallel, if I may, because this Nectin-4 amplification data is pretty immature, it's very small numbers, it's retrospective. The German group are doing, by the way, I agree, a great job. And it reminds me a bit of the Sunitinib story. When Sunitinib first came into kidney cancer, it was clearly better than interferon in pretty much everyone. And there wasn't a subgroup that you didn't want you to, we're going to give you interferon instead. Patients are not, the same with platinum-based chemotherapy. EV-Pembro has superseded platinum-based chemotherapy. And going out to fish out the 1 or 2 patients that can't have EV-Pembro, ending up with platinum-based chemotherapy with all the complications and the poor outcome, doesn't make a great deal of sense. But we did the same with Sunitinib back in the day. We didn't develop those Sunitinib biomarkers. And then when immune therapy came along, we regretted that. So I think that this is not about finding out who has chemotherapy in the future. It's when we talk about the new generation of drugs, about whether actually we can do better with those subgroups of patients. So we should be doing biomarker research. It shouldn't be about saying who doesn't have EV-Pembro. It should be about saying, let's learn for the future.
And I think it's also important to see how the variant histology patients do with that. So you're right, it does not affect our clinical practice, but it'll help us understand if the same therapies can be applied to non-urothelial cancer.
Petros. Kala.
So I was just going to say, and I think the fact that we don't need Nectin testing, we don't do or need PD-L1 testing to give something like EV-Pembro makes it a regimen that should be available quite broadly, like internationally speaking, because I know for us in Canada, doing biomarker testing is challenging. So to have a regimen like this that doesn't require biomarker testing is important. I think from a research standpoint, looking ahead, developing these biomarker assays and understanding where Nectin plays a role is important. But for today, we don't need this for using these drugs.
Petros.
Great point. Two quick comments. Number one, the mechanism of resistance to EV and other ADCs are very important. Also to define the next therapies, the therapeutic sequences that you might ask us, Tom, down the road, or with all those ADCs, could we learn more to inform that discussion by understanding mechanisms of resistance? And that will be a big ask, from the Enfortumab vedotin program to look at that. And is the payload, is it the target, the antibody, maybe both, something unrelated? Would love to see more data in that. But Shilpa made a good point about histology subtypes and divergent histologies. We actually published some interesting data from our research autopsy series at the University of Washington Fair Heart Cancer Center. Our patients were really, amazing to, donate their body after they passed, very humbling. And we saw actually Nectin-4 expression in some histology subtypes like plasmacytoid and squamous. I know this is for your interest, Andrea. And this is, again, early data, but gives us some hints that the target may be there, not only in the classical urothelial subtype. More data, of course, are needed.
So let's summarize the EV story as we met at the moment. We feel that it is transformative and it has superseded chemotherapy, that there is a lot of education and training to be done around the toxicity profile. It's not necessarily more difficult than chemotherapy, it's just different. About half the patients are getting 10 cycles. Petros, are there any baseline characteristics where you wouldn't give EV Pembro to a patient and you'd choose platinum-based chemotherapy instead?
I used EV Pembro in the vast majority of patients. I have to think really hard to find patients who I may not do it. And this may be just very frail patients who wouldn't be good chemotherapy candidates anyway. Patients with ECOG PX of 3 or higher who may need palliative approach or potentially a checkpoint inhibitor monotherapy. Patients with grade 2 or higher neuropathy, that may be a challenge. And otherwise, it's hard to find. There is discussion about the diabetes mellitus, but we don't really know because those were not included in the trial. That does not mean they could not benefit. So we try to control the blood sugars and I try to give them
But you wouldn't, if someone had unstable diabetes, you wouldn't give them platinum-based chemotherapy?
I will still give EV Pembro.
Exactly.
Control their diabetes.
So you control their diabetes,
Right.
and there's no evidence that having diabetes at baseline predisposes you to that hypoglycemia. And
Quite the opposite.
Quite the opposite.
Those who don't have can get catastrophic.
We're going to move on to
There were
Sacituzumab.
data from ESMO, I think, UNITE study, if I remember correctly, that look at these patients with diabetes mellitus and with neuropathy, and those patients could be treated. So I treat them. I just monitor very closely blood sugar and talk to endocrinology in primary care.
We're going to move to Sacituzumab govitecan. It's the second drug which I wanted to talk about. And
Tony has.
Tony.
This is a timely question. I'm sorry, but recently I think someone actually sent me a letter published in European Urology about a model to exclude perhaps or include EV patient. It didn't have diabetes. It had HbA1c. I don't know if you're familiar with that.
Yeah, we actually wrote an editorial for that.
It has merit, yes, no, etc. If you want to comment on it, because I've seen this, noise all over.
So so there was an editorial that was written about a criterion for treating patients with EV plus Pembro, and we wrote an editorial about this because we felt really strongly that we're not there yet, and I don't think it was necessary because we don't have that experience yet, and a lot of the criteria that were being used really didn't have biological basis, like a creatinine clearance. We know that these molecules are large, not excreted by the kidney. So multiple different criteria, including hyperglycemia. I think right now we should treat as many patients as we possibly can with EV plus Pembro because of the doubling of the overall survival. And we will learn as we go along how to manage these toxicities, just like we learned with platinum-based chemotherapy and all chemotherapy. So I think for now, and the frail patients, even some frail patients, I want to start them with like a lower dose, and my pharmacist is like, well, let's try a normal dose and see how they do, and then dose reduce them. And we've done that with a few of our patients anecdotally, and they've done okay. But I do think we need trials for frail patients and understand how to best manage them.
And I want to add that in those criteria that were proposed, like baseline rash, that could be from anything. That doesn't mean they'll have EV mediated rash, just like we use TKIs in kidney cancer all the time with patients who are on 3 antihypertensives. We just have become better internists managing blood pressure. We don't withhold life-prolonging therapies.
It feels like having a series of strict criteria that aren't necessarily related to the drug is sailing in the wrong direction.
I agree.
Agree.
We all agree, I think, in that.
I think we all agree on that.
Yeah.
Let's talk about Sacituzumab govitecan, if we can. Sacituzumab govitecan is a TROP2 ADC. We're putting it second on the list because it is used in the United States. It has FDA approval of a 120 patient study. I believe you were leading that study, Petros. It's a response rate of, I think it's 28% in the updated. It's 27 here. This was the earlier study. 34% response rate with immune checkpoint inhibition, but that was that's second line, not first line.
41% with the new data cut, 41% Saci plus Pembro, platinum refractory second line.
41% there. And then, so that's an updated on this, 41 from 34, so that's higher. It's not 70%.
You're right. It's not 70. It's 41%.
So it's 41.
But it's platinum refractory second
yeah,
line.
No, I did say platinum refractory, and then we got the neoadjuvant 4 cycles of single agent Sacituzumab govitecan. Again, it's one of these neoadjuvant trials. I spent a lot of time on this. I find it hard to interpret. 7 of the patients had a clinical CR but didn't have surgery and therefore may or may not be a CR patient. They were counted them as CR patients in some of these. It's complicated, but it looks to be active. But there were 3 treatment-related deaths in that. So the question to you, Petros, is where do we go with Sacituzumab govitecan? And of course, we know the TROPiCS-4 trial is negative. That's the randomized phase 3 study of Sacituzumab govitecan versus Taxol chemotherapy in PD-L1 and chemotherapy pre-treated patients. I think many of us hoped and expected that to be positive. Because Taxol chemotherapy is not incredibly active in this disease, and not being able to beat that, is that a problem, Petros?
So first of all, I think it's great to have options for the patients, and we all encourage drug development in the field. I think TROP2 is a relevant target. It's significantly expressed in urothelial carcinoma. As you mentioned, Tom, 28% response rate with SG monotherapy. This was a heavily pretreated patient population with a median lines of prior therapy between 2 and 8, so a very heavily pretreated population. Obviously, this can impact response rates. The combination, of course, you mentioned it, 41% response rate with Saci Pembro. The TROPiCS-04 trial data will be key to see. I think will be important to see the granularity of those data, look at survival at both arms, and also look at the issue of growth factor support, which in my opinion is a very important one. I cannot say whether it can explain a big part of the issue TROPiCS-04, but I think it's a major issue across the trials.
So you say the drug has activity, but you're concerned about the toxicity. Is that fair?
I think it's a fair statement, a summary statement, and I think
Kala, your hands
prophylaxis is key with growth factors.
Kala, then Shilpa. What do you make of the Sacituzumab program in the knowledge that we don't know the TROPiCS-4 results?
Fair. So I'm going to push back a little bit on your comment about taxane. So we did a study just before immunotherapy came along, a second-line study of Abraxane versus paclitaxel, and response rates were sitting at around 23%. It was a negative study in that nab-paclitaxel didn't do better, but response rates were around 23%, which is about 15% more than we think taxanes actually have. So I use that sometimes late line when I don't have anything else. So if you combine that with the fact that there is risk of toxicity and neutropenia with Sacituzumab govitecan, and there was some dust, I don't know that I was that surprised about the TROPiCS data, to be perfectly frank.
You weren't surprised.
I wasn't that surprised.
So I feel the bar's a bit low, but Kala's saying it's a little bit higher. So, Andrea, where's your take on this drug? Is this an important drug for us, or is the fact you can't beat docetaxel means actually in the end it's not a game-changing agent? Where are you?
So EV plus Pembro is not 100%, right? We still have patients that are refractory. We have patients that are then refractory to platinum. What do we have next for them? Taxol, okay. But then what next? So if they're FGFR3 positive, or erdafitinib, but I think we need more drugs that are effective. This is a therapy that works. There's toxicity associated with it. It needs to be given correctly. But I don't want to lose a therapy that works for patients.
So you would like the FDA not to withdraw this?
I would.
You would like them not?
I would like them not to withdraw it.
Shilpa, where? Because I'm a European, actually. I still feel very European despite that Brexit fiasco, which...
I'm European too.
Yeah, well, Petros, but you're a proper European. I feel sort of half European now. I feel sort of stuck in the middle of the Atlantic somewhere. From a European perspective, many people say we don't currently have this drug, and if you can't beat Taxol chemotherapy, do we really need it? We had Ramucimumab. That beat Taxol chemotherapy for PFS, but not OS, and we never took that one forwards. And so why do we feel... What's your take on this, Shilpa?
Yeah, my take is a little different.
Is it alive or is it dead?
Yeah, my take is different. Yeah, we saw activity in the single arm trial, and that's why we do phase 3 trials.
Yes.
And if a drug cannot not only beat the platinums or whatever, Taxol or the salvage chemo, but is also more toxic than those agents, then I really don't see the need to have that, because it's really hard to explain to a patient that, yeah, we saw some activity in a boatload of patients in this, but in the large trial, it was actually not even better and it was more toxic. So I think we are getting to, in my hands, like I have not seen neutropenia with this because I give preemptive growth factors, but it was also not more effective. So I would say that, yeah, it's good to have it just in case, but would I really want to offer it to a patient? I'm not really sure.
So your take is you don't mind if the FDA were to withdraw this? Because they're going to have to make a decision. I think it was a provisional approval of a single-arm trial. This was the confirmatory randomized phase 3. There's no other randomized phase 3 out there. So the FDA is probably sitting with this right now, and it's saying, what do we do? And you wouldn't go to the FDA with a negative randomized phase 3, would you? I mean, you wouldn't do that. So they're there at the moment, and it's a difficult choice. And you think they should withdraw it or keep it?
Well, how
I think
negative
for
is
all
it? We need to see the
practical
data.
yeah, we have
Use
not
the
seen the
data.
data, yes. But if it's there and patient has no other options whatsoever, are we going to expect them to live longer? That's probably not the case. So I would say I would love to see what the ODAC
data.
votes on that. Yeah.
Okay, we're good there. So Kala, we're here with a combination of SG and EV, different payloads, different targets, perfect dance partners, response rate out of the Dana-Farber of 70% with some toxicity. 73% according to Tony in the audience. Thank you for your continual interruptions, Tony.
23 patients, 70% response rate.
Who wants to take on Dad? Is this the future of Sacituzumab govitecan in combination, or is this just a phase 1 trial that we're never going to be able to translate into randomized phase 3s?
I think this is exciting, and I think that the response rates, although a really small study, maybe this is a place for SASI, and maybe the follow-up, the DADDY-O, which I love that name, as the next study, combining IO in there, you may get some benefits there. I think it'd be interesting to know EV plus IO compared to the triplet.
We're actually opening a study following this data to corroborate this and validate it. We're going to have a study with EV plus SG plus a checkpoint inhibitor in the first line setting. So we try to get a signal whether we can replicate the data. Of course, we'll do a stepwise approach, phase 1 first, establish safety, make sure the dose is correct, using growth factor support as primary prophylaxis for SG, as we discussed, and build with a potential triplet to see whether we go or no go to a phase 3 trial.
Okay, so there are other TROP2 ADCs with topoisomerase payloads. Are all TROP2 ADCs with topoisomerase payloads, are they all the same? There's T-DXd, there are other agents as well. Does this mean there's trouble for all of these drugs, or should we be doing one at a time? The linker molecule is obviously extremely important. Shilpa, do you want to take that on?
Yeah, we have experience with other TROP2 ADCs, for example, the Merck compound in the early trials.
Don't say anything that's not in the public domain.
Right, sorry. It's an ongoing trial.
Ongoing trial on clinicaltrials.gov.
Umbrella, yes.
But don't tell the results.
Sorry.
Yeah.
No, there is no results, but
Okay,
in our experience, that is not showing neutropenia. So
Okay.
there are other TROP2 ADCs without the same toxicity profile.
Okay, we're going to move on if we may. We're going to come to Disitamab vedotin. Disitamab vedotin is an agent that as monotherapy in HER2, 1, 2, or 3 plus, which is about 70% of patients with a response rate of 50%. It varies a bit, again, depending on the data cut. It looks to have less skin toxicity, but it does appear to have fatigue, and it does appear to have peripheral neuropathy. It looks like an active agent. Matt Galsky presented DV Pembro data with 75% frontline response rate, and in our previous session we described that neoadjuvant cohort with a 61% path CR rate with all of the caveats of the neoadjuvant assessments that we talked about in our previous lecture. What do we make of this drug, Andrea, and where do we go with it? It is in randomized phase 3. It's essentially repeating the EV302 trial with that same control arm, which is going to be difficult in America, Germany, and France, where EV Pembro's approved. What do you do with EV? What do you do with DV? It looks Like, the biggest victim of Enfortumab vedotin's success is Disitamab vedotin. Had we not had this, would have been out-of-the-world data. But coming back to what Petros said before, I suspect there's cross-resistance with the same payload. We don't know that yet. So where does this drug land?
It's a great question, and I think this data is super exciting, but it is the same payload. So, and you have to have the biomarker, but what we saw in the most recent data presented by Matt Gowski at ESMO was that you can be HER2 low. And if you count the HER2 lows and the HER2 highs, we're talking about 80% of the patients with bladder cancer. So now we're not talking anymore about a really small number of patients. We're talking about a much larger number of bladder cancer patients. So where would it fit? I mean, the response rate over 70% when you combine it with a checkpoint inhibitor, so I think that's really exciting. It seems to have activity in the neoadjuvant setting. There was another study, I think it's this one that was presented, that has longer term follow-up in combination with a checkpoint inhibitor that again has an overall survival of 32 months. That was a poster at ESMO. So I think that this drug is very active. We need to figure out where is it going to fit. Is it going to be toxicity? Maybe patients that have rashes or have hyperglycemia. This could be a potential option for those patients in the same setting that you would use EV plus Pembro. Potentially, we need to see the bigger data set, but I think this is an exciting molecule.
I'm going to ask the four of you whether you think there's going to be cross-resistance between EV and DV.
I think there is. I think when you use the same payload,
yes.
I mean, it's like kind of using the same chemo, but the nice thing is that they do have different targets. So potentially you can avoid certain toxicities that are associated with the target and not the payload. But I think with the payload, they're probably going to have the overlapping in terms of the efficacy. It's going to be very similar, but I think that we need to study that prospectively. Like can you, I don't know, this is crazy, but can you potentially give both and see, you're attacking, the payload with two different targets. Is that something that's feasible? Are you going to have higher responses or higher toxicity? There's a lot of questions we don't know, and it all goes back to what are the mechanisms of resistance of these antibody drug conjugates, which we know is not only in the payload, but it's also on the target. It has to do with the linker, with the efflux of the drug. So I think there's a lot of different mechanisms of resistance.
We're going to keep going. We're going to move on from Disitamab vedotin, and we're going to move to T-DXd, which is also a HER2 ADC, but it has the potential advantage of a different payload, assuming that EV Pembro is going to be widely used, or EV Durva-Tremi potentially in the neoadjuvant setting. T-DXd is an agent that has FDA approval, and you're using it in the US. I've used a tiny amount, and I haven't got a huge amount of experience. One or two private patients come darken my door with having been on an array of drugs. But I speak to my colleagues and friends in the US who quite like this agent. The label is associated only in the HER3+, which is only 20% of patients, not the 70 or 80% that Andrea mentioned. When you look under the bonnet at this basket study in detail, that only represents 16 patients. It's unusual to get an FDA approval of only 16 patients. The response rate is 52%, which is high. But when you look at the concordance of the immunohistochemistry done centrally and locally, the concordance is lacking. It actually looks like we're not good at measuring HER3 anyway. So where it's high to one person seems to be different from what's high to another person. This therefore appears to me to be a hugely grey area around defining this high population, but this does look like an active drug. Is this more promising than Sacituzumab, govitecan? Or is this going to end up in the same basket with nice phase 2 data, accelerated approval, but a negative randomized phase 3? What's the future of T-DXd in bladder cancer? And Shilpa, I'd like you to start with that.
Yeah, I think we can't really compare it to Sacituzumab govitecan. That is not a biomarker selected drug. This one is for HER2 3+, and to your point about the IHC, this one follows a unique measurement of the HER2 based on the gastric cancer, not your routine breast cancer way. But I think it certainly has promise, and Andrea, like she said, what after EV Pembro? We need novel therapies which are effective, and if they're biomarker driven and well tolerated, I think yes, this drug has a future, and we need such novel agents.
Kala, on a scale of 1 to 10, how excited are you about this drug in bladder cancer?
Yeah, I mean, I would say about a 7 or so. I think it's interesting. It's a different mechanism of action. And I mean, one of the things just to, think about SG for a moment is that, during the pandemic, one thing that we were advised to do is to try not to give chemo, which is really hard as a medical oncologist to not give chemo. But we've been using a lot of G-CSF in our patients who have been getting chemo across the board of GU tumors, and we've seen significant reductions in neutropenia and all of that. So I think it's something to think about, that neutropenia in our patients is a big deal. And with SASI, I think we need to think about that even more. As we look at this drug, it has a different toxicity profile, and this is sort of what Andrea was getting to, the fact that we may be now looking at how these toxicity profiles play out in terms of deciding in a drug that has a similar efficacy, which one are you going to choose in which setting?
There are no randomized phase 3s announced that I'm aware of in bladder cancer for this. I was under the impression that you had to do a confirmatory randomized phase 3 if you had FDA approval. I've not seen that study launched yet. We'll have to wait and see.
But we are getting HER2 testing on all our patients, and we are starting to give this drug, and I'm excited about it. I've seen efficacy, so I think it's exciting drug.
And it's great to have options for the patients, and I think the good point that you mentioned is the HER2 staining has to be with the right assay, so it's a gastric cancer scoring algorithm, and now we're talking with pathologists and say, guys, can you please test
We
HER2?
need to work on this issue because not everyone's doing that.
Because we're not doing testing.
That's not like that. It's the Wild West out there, I tell you.
And that's a big need. So that's a major issue. The right assay for the right
We've got to
stain.
keep going. We've got to keep going. BT8009 is a Nectin-4 targeted drug with MMAE as the payload, but actually it's a small molecule conjugate. It has a different structure to the ADC. It's called the bicycle because apparently it looks like a bicycle, though I think it looks more like a steering wheel from an arcade game to me. But if anyone else can show me where that, or even a hose pipe, but not a bicycle. But that's where we are with this. Single agent response rates, this is Johan Lorio's data, Juvelo phase 1. Single agent response rates of 45%, EV was 40%. The adverse event profile looks quite attractive actually. There's issues around whether there's less skin reaction and less neuropathy. It's only 45 patients. I think we need to wait and see. As I said before, cross-trial comparisons of adverse events of phase 1, very, very risky to do. This is also in a randomized phase 3 study. Again, it's very similar to EV302, GemCis versus this. It's also got a relatively complicated phase 2 program. Who would like to take on this drug and the future of this drug and where it goes?
I think that I will quote what Andrea mentioned before, that it's a matter sometimes of toxicity when we envision a future when we have
need
more than
this
option.
drug? We've already got EV Pembro, we've got EV.
Yes, we always need more drugs because this is a novel mechanism, and I think we can build on this. Maybe not with this target, but I think this is a really interesting mechanism.
And also we're going to see whether there is cross-resistance with EV. I think the company is looking into EV-resistant patients to see whether this has activity. I think we're going to end up in a future state, Tom, like RCC first line, right? We have 4 standard of care options there. Right now we have that trial, phase 3, looking at this compound plus checkpoint inhibition versus the Javelin Bladder 100 regimen, and we have the DV plus Pembro versus the Javelin regimen. So we may end up in the future with 3 positive trials, and then how do you decide? Are we going to be forced to use biomarkers like HER2 or others? Are we going to look at toxicity or both to make a decision for our
Kala,
patients?
what's your take on it?
So, I mean, I think that the one aspect about this drug that might be particularly interesting is a lack of neuropathy or lower neuropathy than we see with EV. That could be important. It might also be interesting that if EV Pembro moves earlier into the MIBC setting,
There's
it's just something
16%
later
grade
on.
2 neuropathy.
Yeah, I mean, it's a little bit
Not
better,
50.
I think.
It's not 50, but it's still neuropathy. And grade 2 neuropathy that's not running around.
Right.
Neuropathy, CTC criteria are not great. Grade 2 neuropathy is actually quite serious. And so, but don't get me wrong, it does look, in indirect comparisons, it looks lower
It looks
than EV.
a little better.
But it depends on how you grade them at home.
Yeah. It is a different mechanism of action, which I think is going to be interesting, and we'll see how that plays
So
out.
it definitely has a future. So let's go for scoring a 10 out of 10. Because you might say, well, do we need another one of these drugs? It's very similar to EV. Assuming it's active, and assuming the randomized phase 3 is positive, how out of 10,
I think it
how relevant
depends
is
on
this?
which space you would want to use this in. If the future is EV Pembro moving in the neoadjuvant space, we do need such
Can
drugs
I be a bit
in
cynical and interrupt you?
Sure.
Very unusual.
Yeah. So look, EV302 comes in with hazard ratios of 0.4. Repeating that's going to be extremely difficult. There's more access to subsequent therapy. The trial conduct's going to be more difficult because patients won't want to be in the control arm. They'll be piling off looking for other things. So repeating those is going to be hard. So inevitably, this is likely to come in the 0.6s, not the 0.4s. If the results are if they're not as good as and Gemcis and Evo was not, was in the early 0.7s and late 0.78 for OS. Do you have to have as good a result as EV Pembro to compete with it? Or does it just need to be a positive trial? Because we've got positive trials with Gemcis and Evo. The reason why EV Pembro has superseded Gemcis and Evo was so positive. But if the results come in and they're not so great, is it competitive?
I think it would be in terms of the toxicity profile being different. It's good to, like Petros said, having multiple options like the RCC field, because the trial of this versus EV Pembro is never going to happen.
Shilpa, I'm going to interrupt you again. So the pazopanib story, we did sunitinib versus pazopanib. We did those non-inferiority trials, and pazopanib came out as better tolerated, Pisces, better quality of life, but there was always this issue about whether it was a bit less active. It never really took off. Being first and having better results is going to be hard to compete with, isn't it?
I think yes, but the more we see such drugs and better patient-reported outcomes, better toxicity profiles, I think it's going to be very good, because one approach cannot be right for all patients.
Someone else pushed back on me a bit, saying not being first with not quite such great results is going to be very difficult.
Think about that Atezolizumab in metastatic urothelial carcinoma. It was the first checkpoint inhibitor approved.
Yes.
Right now, there's no approval in the US. I don't say this will happen, of course, with Pembro, not at all. But my point is that...
But 211 was negative. The randomized phase 3 with 10, whereas EV Pembro came with a hazard ratio of 0.47 for OS.
And I predict that EV Pembro will remain the standard of care for a long, long time. It's very high bar to beat. It's very high bar. My point is, being the first there doesn't mean you're the only one there. So we have seen that in other tumor types. So I agree with colleagues that we need to have options. And at the end of the day, we're going to look at all these trials. I don't think we can compare hazard ratios across trials, because exactly what you said, Tom. The subsequent therapies may be different, and that can impact the hazard ratio to multiple dose trials. So positive trial will be good. EV Pembro is a very high bar to beat, but those trials do not compete against EV Pembro.
But to your point, Tom, the comparison of the control arm, it's a bit too late, so that's why the future of this agent might not be in the frontline setting, but subsequent setting, post-EV Pembro.
But we don't know there's resistance yet. We don't know that we can't give it post-EV. I mean, you would think that maybe you can't because it's the same payload, but we don't know yet. And I think understanding these molecules and attaching different payloads to them, my dream would be multiple payloads, because, as a medical oncologist, we give combination therapy, so why not? That's why I like the DADIO study, because I think that if you can attack the tumor from multiple different directions, that's the way to go. But we need the chemist to work on that. But I think the molecule is very exciting.
We've got the last drug here that we're discussing today, EGFR HER3 bispecific, topoisomerase the payload, data out of China, relatively small numbers, 22 patients. And you can see here response rates of 40% again, 41%. A novel target, obviously, completely different from what we've talked about so far. We don't know enough about this drug. On the stage at ESMO, they announced 2 randomized trials that they were going to launch, randomized phase 3s. We didn't get too much of the detail of those, whether they were China only or global. Who wants to take this on?
Sure, I can comment. I think it's exciting just because it's a different target. I'm excited to see the EGFR, I'm excited to see the HER3. It's doing something different, and that itself is exciting for me. I think the objective response rates, this was in all comers, but I think in patients who had only one line of treatment, it was even a little bit better than that. So I'd be curious to see where that goes.
Any more questions on this before we move on this drug here? We're excited about it, I guess, but we don't know enough. Is that fair?
Yeah.
We don't know enough.
It's early.
Small study.
Petros.
Small study, we need more data, I agree, but that's interesting. It's an interesting compound.
It's an interesting compound, yeah. It's
sure.
just
Very
The
interesting.
dual
Relevant
bispecific.
targets.
So
The nuance actually in the presentation, they quoted that they had data in the second line, but actually if you look at the actual data, they had also data in the subsequent line. So I think it's relevant to look at the detail. The drug is active.
22 patients. I gave you a small task before we started. And what I said was there are different settings where you could develop a cancer drug right now, going from the neoadjuvant, CTNA positive, first line going against EV Pembro, second line post-EV Pembro, third line against taxane therapy. And then you could do monotherapy in all comers, monotherapy biomarker driven, and then combinations. So basically, what I want you to do is I'd like to give you the task of allocating you a drug. I've done that already. I'm going to try and remember which one I allocated to what, which I can't right now, which is why I'm pausing for a second. And then I want you to tell me, if I gave you that drug, you were globally in charge of it from a pharmaceutical company perspective, what one trial would you do to get an approval and get it used globally, not accelerated approval in the US? Shilpa, which one I gave you? I can't remember which one I gave you. I think I gave you Nectin-4, didn't I?
Yes, you did. Yes.
So this second generation Nectin-4, I apologise, I think that's most difficult.
I would
Nectin-4, so just to be clear, that would be the second generation of drugs, but there's also some Loxo drugs as well, looking
Correct.
at different payloads. Do you want to far away?
Yeah, so we have several novel Nectin-4 drugs like the Bicycle one you mentioned and the Lilly one, which has a different payload. It's capsaicin, it's not MMAE, so the toxicity profile is different. If looking forward few years from now, we think that EV Pembro will move to the neoadjuvant space, so versus EV Pembro frontline trial is going to become a moot point. So to me, the best bet would be post-EV Pembro versus platinum, because platinums do have activity post-EV Pembro, and we want to look in that
Single
setting.
agent, all-comers, Nectin-4 re-challenge with a novel agent.
All comers, because we know Nectin-4 is expressed ubiquitously. I just would not give IO after IO.
Yeah?
But I would do these novel agents. But I would be tempted to use, for example, combine different ADCs. And their SG may play a role, or T-DXd may play a role. Any of these we could mix and match in the second line or third line versus
anyone would
platinums.
comment on Shilpa's approach?
I think it's a great point, Sil, but the challenge is we don't know the mechanism of resistance, and we don't know if you lose Nectin-4, will that impact the ability of beating platinum. I think platinum is a high bar in the second line setting, so I think we need more information to position
But she
the
was
drug.
saying it in combination with the platinum.
Yeah, in combination with platinum, yeah.
Combination with any of these, like
Right.
the DAD.
So it's the
After we
Nectin-4
have
combination,
safety
all-comers trial post-EV Pembro. Kala, I can't remember which one I gave you.
So the EGFR HER3, I mean, I feel like the biggest,
So this is the novel EGFR HER3, the one we just talked about.
Yeah.
40% response rate, not much data, but completely novel.
Yeah.
Although it has obviously a topoisomerase payload, which is
Right.
different from MMAE and EV.
exactly. So, I mean, I think the big unmet need right now is post-EVP. I
Yes.
think that's where I would put that drug. I mean, it's encouraging response rates. I think there'd be enthusiasm for it because patients don't want platinum-based chemo, so they have another option. That's probably where I would do it. I'm not sure about this concept of retreatment with IO. We've seen 2 negative trials in kidney, but is bladder the same? I'm not sure I know the answer to that yet, and I think we need to figure that out.
So that would be HER3 ADC versus platinum chemotherapy versus the combination of EV platinum chemotherapy with an immune checkpoint inhibitor.
Right.
3-arm trial.
Right.
Okay, I love that. Andrea, which one? I gave you DV, didn't I?
DV, so
The most difficult, I suspect.
I think it's hard, right? Because you have EV plus Pembro. I would test it in the neoadjuvant setting. Same kind of question, but I would do an adaptive design in the adjuvant setting, treat in combination with IO, and it would be another option, another treatment option. I would compete right in the front.
Compete with EV
I would
Pembro?
go right in the front, yes.
Competing with EV Pembro,
Yes,
brave.
I would.
Directly or different trials just showing as good as results?
As good as results. I don't think
I agree.
directly that's going to be a tough one. And then just quickly, the question about subsequent IO. I mean, I don't know if we can take the kidney data from the trials and say we shouldn't be giving EV plus Pembro if the patient got adjuvant immunotherapy. I don't know the right answer for that. I would say I would do it because I think there's a synergy there. And I don't think that you've burned your bridge if you've given it in the adjuvant setting.
We're going to vote on it after the last fiasco vote,
Okay.
where there was no option. We're
Okay,
re-voting.
yes and
We
no.
are re-voting. Petros, I've given you the whole of topoisomerase, TROP2 topoisomerase 1 payload. So TROP2, what's the future of TROP2? What would you do developing it now, knowing the only randomized trial we have in public domain is negative?
I will give you two answers. Number one, I will try to answer Andrea's great question about the IO retaliants, and I will announce here in the group we have an ongoing, ready-to-launch phase 3 trial.
This is self-publicity. I've done it a lot in my life too.
No, it's okay. It's
yeah,
okay.
no, I've got no problem with it. I'm just announcing it as what it is.
It's
That's
public
all.
information. It's
No,
good.
no, I realise that. But yeah, okay, far away, Petros. Talk me through your investigator-initiated randomised trial.
It's a phase 3 trial. It's cooperative group. It's approved by CTEP, I think, at this point, or at least we're getting the final approval by CTEP. It's approved by CIRB, so we're waiting for the CTEP approval. Approved by GU Steering Committee. It's Sati plus Pembro versus Sati alone. And you're going to ask me what will happen if the label goes away. That's a good question. We'll have to discuss that, but the trial is committed to happen anyway.
Okay.
And we will answer the IO retaliants question that Andrea pointed out, which will have no data prospectively in bladder cancer. We have 2 trials in kidney cancer, but we need to answer the question in bladder cancer. To answer your question here, I believe in TROP2 targeting. I think TOP1 is the right payload. I think TROP2 is the right target. I would try to position as a first step post-EV-Pembro, post-platinum against taxane or vinflunin and try to have a fully approval stage there as monotherapy.
A repeat of TROPICS-4?
With some better way to design it and better way of using growth factor as primary.
But you wouldn't use the
prophylaxis.
same drug again, would you? You wouldn't do Sacituzumab govitecan. You couldn't repeat TROPICS-4 with Sacituzumab govitecan.
You can potentially think about another TROP2 approach.
No, yes or no? Repeat. You wouldn't repeat a randomized 700 patient randomized phase 3 negative trial. You would do the same experiment twice with the same drug.
If you do it right. If you do it right, you could. Or you can take another drug in that case, but you use the right approach.
What, would you just keep doing the trial until it's positive?
And if you keep doing the trial in that way, this person.
We're done with time. These are the audience questions. First question here. Fabulous. Which of the following is likely to have the biggest impact on bladder cancer in the future?
You didn't ask which space, but...
But no, just the biggest overall impact, because we've talked about different spaces. I'm going to try and vote if I can. I don't know if I can multitask like this. I'm going to have a go, see how I get on. Isn't that interesting?
What's T-DXd?
Okay, should we stop in about 10 seconds? We've got a couple more questions. We've had 34 votes, 36 votes.
Is that T-DXd or D-DXd?
D-DXd or another TROP2.
The TROP2 says.
And Sacituzumab govitecan's right at the bottom there. Now, I didn't mean the bottom as in last. I mean, you can't see it in the bottom. I'm sorry, I apologize. I wasn't giving a running commentary on the scores. I wasn't saying, I just wanted to say that it is there. It is there. It is there. I think that came across. This is going to be a podcast. This is going to be awful because I'm not a podcast. They're only going to see the screen. So, for those of you at home on the podcast, Disitamab vedotin 44%, T-DXd 28%, EGFR HER3 13%, TROP2 ADC 10%, Bicycle 5%, and Sacituzumab govitecan probably about the same at 5%.
Zero.
Okay, so that's the first question. We're going to move on to the next question, if we may.
No, I think we only had one.
Oh, no, here we go.
Oh, you fixed this?
But they didn't fix
It's
it.
not
There's
fixed
no.
though.
Oh, we need a no question at the bottom. We're going to draw a line under this. We are going to ask this question at some point before the end of our meeting.
You have to ask the right question.
We're going to ask the right question at the beginning of tomorrow. Many thanks for your attention. Many thanks to the panel.
Thank you.